Hello everyone, in this video we are going to discuss a high-yield MCQ. So coming to the question, a 64-year-old man with a 40-pack-year smoking history presents with progressive shortness of breath and weight loss. And physical examination revealed hyperresonance to percussion and decreased breath sounds bilaterally. Pulmonary function tests show FEV1 is 45% of predicted value and FVC is 80%, FEV1 by FVC ratio is 56% and DLCO, that is diffusion capacity of the lung for carbon monoxide, is decreased. High resolution CT shows enlarged spaces and destruction of the alveolar walls, predominantly in the lower lobes. A lung biopsy confirms the absence of fibrosis and shows pan-acinar distribution of the damage, as you can see in the picture. So what is the mechanism which is contributing to this condition? The options are goblet cell hyperplasia, inhibition of alpha-1 antitrypsin, CD8 plus T-cell mediated alveolitis, impaired mucociliary clearance and increased pulmonary capillary permeability. So let us think about the diagnosis first, then we will see what is the mechanism which is causing. So whenever you see such questions, you should start from the history. So there is a smoking history and also progressive shortness of breath along with weight loss, and examination reveals hyperresonance to percussion and decreased breath sounds bilaterally. So it is a bilateral condition. The important thing is FEV1 by FVC ratio is 56%. Whenever the ratio is less than 70%, it indicates an obstructive condition. So it is an obstructive disease, and DLCO is also decreased. So diffusion is also decreased, and biopsy shows fibrosis along with pan-acinar damage. So, and there is absence of fibrosis and it shows pan-acinar distribution of the damage, alveolar wall destruction. So it is more towards a COPD, that is emphysema. So there is pan-acinar emphysema. So what causes pan-acinar emphysema? Is goblet cell hyperplasia causes? No. CD8 plus T-cell mediated alveolitis? No. Impaired mucociliary clearance? No. Increased pulmonary capillary permeability, it is not seen in this condition. So the answer is pan-acinar emphysema due to alpha-1 antitrypsin deficiency is an answer. So B, option B is the answer. So let us see why it is. So as we know, COPD, in COPD emphysema is a part of COPD. So here there is decrease in the ratio of FEV1 by FVC, decrease in DLCO and destruction of alveolar walls without fibrosis. This is hinging thing. Then in alpha-1 antitrypsin deficiency, what happens is there is unchecked neutrophil elastase breakdown of the elastin. So this leads to alveolar destruction. So this alpha-1 antitrypsin will actually inhibit this. Whenever there is deficiency of this elastin acts and it causes alveolar destruction. So leading to alveolar destruction without any fibrosis. So why we have to see why the other options are not correct. So goblet cell hyperplasia is seen in chronic bronchitis. Here we will not see the condition like shortness of breath and along with that we will see the patient is having very obese patient with shortness of breath and cough, productive cough we will see. So, and these are blue bloaters. So cyanosis will be present in chronic bronchitis. This history is not given in this condition, so it is not chronic bronchitis. CD8 plus T cell plays an important role in COPD, but it is not a primary mechanism of alveolar destruction, so it is not a correct answer. Impaired clearance is generally seen in chronic bronchitis, which is associated with cystic fibrosis. If it is associated with cystic fibrosis, it will exacerbate this condition. So it is not a answer. Capillary permeability is increased in acute respiratory distress syndrome, not emphysema. So this is also not a correct answer. So the correct answer is inhibition of alpha-1 antitrypsin. So what is the thing we should remember is whenever there is smoking history, centrilobular emphysema will be there. But in this question, there is pan-acinar emphysema. So pan-acinar emphysema, the complete whole lobe is involved. So pan-acinar emphysema, we should always think of alpha-1 antitrypsin deficiency. So pan-acinar emphysema is almost always indicative of alpha-1 antitrypsin deficiency. So we should always remember this. So this is an important question. So this is an important concept. So the takeaways from this question are the alpha-1 antitrypsin deficiency will cause increase in the elastase, causing breakdown of elastin, causing alveolar destruction. There is no fibrosis. Alpha-1 antitrypsin deficiency causes pan-acinar damage of the lungs. There is no fibrosis and there is decrease in the FEV1 by FVC ratio along with decrease in the DLCO. So this is the high yield MCQ.